I'm going to make 3 brief points, but before I do, I want to say 2 things related to things that have been said earlier in the day. And take it first starting with one step beyond what Joe said, which is to thank David Kent and express the gratitude for keeping the torch burning for all these years. And with his backup, Rod Hayward, who I would call the general manager of that group, because heterogeneity of treatment effects is not a sexy subject. And recently, Sherry and I put together an observational study based on registries from the original trial that Corey sponsored, Dave Penson's trial, in which we added a genetic set of markers and called it precision medicine, and it got funded, and we're doing it. And it's all about HTE, but we never mention HTE anywhere in the project. And the other point I want to make is that there's a lot of people who think this work is for pointy-headed individuals who do very arcane things. Everybody here excluded from that group. But in fact, I see 2 things, I'll give some examples, of immediacy. One came up today already, which is the DPP. I read somewhere where CMS is having trouble sponsoring the whole thing. And if they paid attention to the Sussman models, they would focus on the groups most likely to benefit, save money, and improve effectiveness. That could be actually put into action literally today. Another topic, and there are many, is the PSA controversy. PSA is really all about subgroups. And in our current work, and other people are doing this too, we can now or soon divide people into risk groups, based a lot of it on patient report, which I'll get to. But in any case, we can divide people so that they can see what's going to happen to them and be able to make choices, which would move everybody closer to active surveillance and solve some of the arguments between the urologists and the generalists. So there's just 2 examples of things that are very close to being put into action right away. Now I'll make 3 points. One is the beautiful work done here by and articulated by the panelists, and I would say, let's get on with it. In every trial, there should be predictive models of the sophisticated type embedded in the trial, not only to improve the analysis of the trial, but also so we don't have to wait forever and retire before the studies come out. Or before the trials are so old they're not relevant anymore, like Sprint. So I think it's time that we can get on with it and put them in there, and actually, as talked about in cancer, which is actually do preformed groups, some form of stratification ahead of time. So that's one point. Second point, and some of you will not be surprised that I'm venturing into this, a little bit left field, which is enlarge the group of variables to include the personal variables, the risk variables that individual patients have. And I'm talking about comorbidity in elderly people. Not elderly, 50, 55. 45 is okay, but everybody has some comorbidity. Functional status, which in a way is a response to disease. Depression. Patient participation in care. A lot of these are Sherry's variables, and she's here, she can talk about, which affects the ability that patients participate, affects their adherence. And finally, social determinants of care, which are basically completely left out of randomized trials. In some of our current work, and some of it's in the book, Sherry put together a composite which is able to, of these things, which is able to be put together, as a clinician will understand it, because there's a latent variable. The latent variable is ability to respond to treatment. These days, they all come from patient report. The knock on patient report is paper, pencil. Now we can automate through REDCap, we can automate patient report, can be actually put into the EMR if somebody wants to. And we can actually automate the scoring of these multivariate scales as well. And therefore we can deal with complexity. And I learned as a clinician, from my colleague Sherry Kaplan and many others in this field, that when they deal with colinearity, it's in their souls. Colinearity is not some extra thing that people figure out. Colinearity is part of all psychological models, and so it has to be dealt with. And the final point, is that observational studies. Hal Sachs is here. The original vision of CER was to develop data from learning health systems, observational studies. I'm not talking now about big data, that's a separate topic. I'm talking about intermediate and small data, hundreds, maybe thousands of people, studies that are being done more and more and more, and eclipsing randomized trials, which have their own problems, as we found out. These observational studies are the rich source of HTE, and by definition, it includes subgroups. That's the way they're formed. Our registry study, we have far too many subgroups, of course, but we're trying to deal with them. And of course, the big challenge is dealing with bias by indication versus true differences in subgroups. Now, Sherry's made some progress. I'm sure many people in the room have tried to work on this, and I hope we'll hear more about this during the day. But I think we've got to move ever more toward using the data that we have and are able to collect. So I'll end there saying much appreciate what happened earlier and looking forward to the rest of the day. Thank you very much.